afternoon everyone, my name is Emily Ford and a student from the University of Canberra. Okay, thank you for taking the time out of your day to listen to my presentation. Today I'll be discussing the importance of your mammogram, of your patient's mammogram more importantly, okay? So I'll cover a general overview, the physical principles, a case study and what occurs after detection. I wanted to discuss the important aspects of mammography today, as only a few radiographers in this room are actually able to do so. Some of the males in this room probably understand the daily quality assurance, and for myself I want to help understand a little bit more what's involved in the processes. So I'm going to aim to discuss and explain what's involved in mammography and hopefully give a little bit more information regarding this modality. If you have any questions, please keep them aside and I can answer them for you once the presentation is finished. So, a shocking 1 in 8 women will develop breast cancer by the age of 85. So this is according to Breast Screen Australia. Not only do women develop breast cancer, but males also. However, their chance is only 1 in 14. So currently, mammography is the gold standard for detecting breast cancer and for examination of clinically detected abnormalities. There are 2 services offered to patients. This is Breast Screen Australia and diagnostic mammography. The difference between the 2 is that Breast Screen Australia is a government-funded screening program, and this aims to detect early breast cancer through its preclinical stage. Through population screening, it was found that there is a 30% reduction in mortality rates as well. So diagnostic mammography investigates the clinical symptoms, it monitors the patients with a history of breast cancer, and it may include other modalities such as ultrasound and MRI. It's also subsidised by Medicare Australia. So as you can see in the image provided, there's adipose to glandular tissue. Whilst younger patients have glandular breasts and older patients have had more adipose breasts. As women age, they lose glandular tissue and increase in adipose tissue. This is the reason why screening in Australia doesn't start till the age of 50. So because there is increased difficulty in visualising a tumour in a dense breast. However, in saying this, the normal breast variations are dependent on many factors, so such as age, genetics and menstrual cycle. Generally, mammograms and ultrasounds will be booked together for patients that require them both, and ultrasound is able to complement mammography projections and characterise the lesions a little further. MRI is able to provide a differential diagnosis of the type of lesion. It doesn't introduce ionizing radiation either. So gadolinium is generally used, and it's just able to change the T1 weighting and enhance the tissue a little further. So the disadvantages are high cost, longer scan time, and low spatial resolution. So each mammogram performed is catered to the individual to ensure a pleasant experience and successful diagnosis. One of the techniques acquired is through the use of specific anode filter combinations. The woman's breast size and composition will impact the selection of anode filter combination. So by having a large range of these anode filter combinations, we can basically shape the X-ray spectrum, okay? And this is just depending on the size of the patient's breast. So the most common anode filter combinations are molybdenum and molybdenum, molybdenum and rhodium, 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 tungsten and rhodium, and tungsten and silver. So as displayed on the graph, I want to draw your attention to these vertical peaks. So these are known as K-edges. The K-edges demonstrate the absorption edges of molybdenum and rhodium, which is what we've used here. And this is just our anode filter selection. So just to quickly explain the concept of K-edges, the initial descending curve is our Bremsstrahlung radiation, and the vertical peaks represent characteristic radiation, both of which are required to create a monochromatic beam. So the characteristic peaks generally range from 24 to 32 kV, and this low energy spectrum is required in order to produce high subject contrast of the breast. So this contrast is really vital because anatomically, the structure of the breast and different lesions, if there are any present, aren't that different. So we need that high subject contrast to differentiate between the 2. So we can imagine the K-edges as a perimeter between photon energies. So the photon energies that haven't yet been attenuated and the photon energies that are soon to be attenuated. Alright, so the atomic number of the material is able to determine the binding shell of the K-shell electrons. So molybdenum and molybdenum anode filter should usually be used for a fatty breast, so more adipose when it's compressed at 4 centimetres. Molybdenum and rhodium, probably more preferred for a glandular breast when it's compressed 5 to 7 centimetres thick. And that's obviously a larger thickness because it's got more glandular tissue, meaning a little bit hard to compress, and also depending on the patient's pain tolerance, they may find that a little bit more difficult as well. So this is because molybdenum has a lower atomic number of 42, whereas rhodium has a slightly higher atomic number of 45. So if you guys imagine an atom, we've got the nucleus inside and you've got your different shells. So the inner shell is what we call the K shell, and that's the binding energy and the X-ray spectrum is created when it moves around. So you've got your K, your L, M, N shell, and this is why it's moving. And that inner shell, that's why they call it the K edge, because it's the effect that that has when everything's moving around. Alright, so by this we can already make an observation of how the K edges can be manipulated and shifted when the appropriate anode filter combinations are selected. A recent study featured the Iranian Journal of Radiology suggested that tungsten and rhodium anode filter combination is best choice for mammographic imaging when compression of the breast is between 4 to 6 centimetres. So if it was a little bit less, which is, if you're a very good mammographer, you can get a little bit less than 4 centimetres. However, if it's a little bit more, depending on the density, depending on the thickness, you may have to go for that slightly higher anode filter combination. So the tube head angulation also allows for uniform exposure and utilises the anode heel effect. So the exposure of the breast won't be as uniform for a straight tube with divergence. Again, this is probably a bit more important when we had filament CR, however it still does make a difference with DR. So by angling the tube away from the patient, the cathode will be directly above the chest, and this makes sense because this thicker anatomical region does need higher attenuation than, say, the nipple, which is lying underneath the anode, so it gives a smaller anatomical landmark and gets a little bit less. Alright. Okay, so compression is also a very important aspect to the mammogram. However, the patient can only withstand so much, and pain thresholds differ between their age, their menstrual cycle. There may be some pathology as well, so they might have an abscess. If they've got discharge when you're compressing, that may be a little bit uncomfortable as well. So this is what they fear the most upon approaching their mammogram, okay? And only this short period of discomfort, it's obviously has the ability to save their life and provide a diagnostic image for the radiologist. So we use compression for the following reasons. It reduces superimposition of the breast, so this increases visibility of any abnormal lesions and also differentiates between the normal anatomical structures. Penumbra is reduced, so this means when the breast in the planes decrease from any plane to the imaging plate, we also reduce geometric unsharpness, okay? So dose is also decreased as less radiation is required to attenuate a small breast, and compression also allows for more uniform attenuation. The image unsharpness is decreased as the compression reduces anatomical motion, such as chest wall movement. So this is probably more of an issue for larger breasts or women where the chest is moving from the breathing. So the mammography unit utilised at the Robina campus has an OP dose selection, and this allows for high subject contrast and reduced dose, whilst using a tungsten and rhodium anode filter combination. However, a minimum of 30 newtons of force is required. So again, not all patients can withstand this. However, some patients can withstand up to 70 to 80 newtons of force. It's really dependent on them. However, if less than 30 newtons of force of compression is applied, the AEC or a manual exposure should be set, depending on what's most appropriate. Okay, so quality assurance. It's really vital that the quality of dedicated mammography units are maintained, otherwise serious consequences may occur for the patient. Through implementation of necessary quality assurance, the standard of images and reporting can be maintained. So daily QA consists of placing a 4 cm perspex plate on the detector plate and compressing to a force of 50 newtons. The resultant image should be then inspected using the zoom tool. In the case of any artefacts being found, the perspex should be rotated 180 degrees, so just moving it like that, and then repeating the exposure. So if the artefact is again found, but in a different location according to the rotation, it's very likely that's part of the perspex, not the mammography unit itself. However, if you're still unsure, just cleaning everything down, repeating it again. If you're then unsure, we'll just call some people and have a look at everything. Okay, so weekly the accreditation phantom should also be used. The benefits of this QA method is detection of tumour-like masses and microcalcifications. So as you can see from the example here. So this phantom is a 4.2 centimetre compressed breast, basically mimicking 50% adipose and 50% glandular tissue. The image demonstrates the location of test objects and a wax insert. So this is what it looks like. Obviously radiographically a little bit different, but the same type of pattern should be present. The phantom tests the contrast sensitivity and simulates the amount of masses, fibres and microcalcifications the mammography unit is able to detect. So the breast questionnaire, this is asked with every patient and allows the radiographers and doctors to basically have a baseline and track the patients through any screening that they may have done. And they also helps us cater to the individual's needs. It's important that the patient stops breastfeeding 3 months prior to their mammogram. If not, full milk ducts may superimpose microcalcifications. We also ask about their menstrual cycle and recommend that they schedule it mid-cycle. So this is when they have high pain tolerance. Hormone replacement therapy can significantly impact breast density from the change in estrogen levels. Not all patients will remember what it is exactly that they're taking, but if you ask if they're taking tamoxifen or Femara, they may respond in accordance, and you can write down that one. So previous breast imaging is important. Again, comparison, having a baseline, seeing how they're feeling tracked. If the patient has any concerns such as scarring, lumps, discharge, dimpling, redness or skin changes, should be recorded to help assist doctors and their future diagnosis. So on the questionnaire, on the back of the page, you will have just a 2-drawing 2 breasts, and you can draw anything on there. So scars, but that scarring could even be from surgery, the lumps could be from surgery, or fat necrosis as well. So family history is also important to record, as genetic testing can be requested for the patient. If the patient has the BRCA1 or BRCA2 gene, they have an increased risk of developing breast cancer and should start the process of breast screening earlier than what is required. So if they've undergone your previous surgery, just recording that down. Alright, so just moving on to the case study, we had a 54-year-old woman presenting to a clinic with a palpable lump, okay, of the right breast and skin retraction inferior to the right nipple. So these images were not done at Robina Hospital, they were conducted at another campus, but the patient came back recently, post-mastectomy, just for follow-up. So this was their images 1 year ago. So the cranial caudal view, for that to be acceptable, the nipple must be in profile with a deviation of no more than 5 to 10 degrees. Okay, it's important to include enough lateral and medial breast tissue. An acceptable amount of pullback needs to be achieved. So the term pullback basically means you can see a bit of pec muscle, and that basically represents all the breast tissues being included back to the chest wall, so you haven't missed any lesions. You can see on the CCV that we probably could have got a little bit more, but we've done as best as we could, and this resembles that the entirety of the breast has been included. So for the medial lateral oblique to be acceptable, the nipple must be in profile. So generally, if you've rotated too far towards the imaging plate, you'll see that deviating towards the plate. If you've rotated them not enough, so they're too externally rotated, you'll see the nipple deviating away. So you can easily fix these two visually as well. However, if the patient has had previous surgery or any cosmetic changes, there may be some nipple rotation which cannot be avoided, and you can just put a little note down on their profile. So generally the IMA, the pec muscles also included down to the nipple line, as you can see here. Again, just confirming we've got enough breast tissue on back to the chest wall. And the IMA should be positioned at an angle of 90 degrees. Okay. The adjustments to auxiliary structures can then be made as they're leaning over the set. So it's really important when you're positioning in this just to hold your hand, supporting as much as you can, and then as the paddles come down to compress, you can brush your hand out and remove any skin folds as well. So besides removing skin folds, you're also able to maintain that 90-degree IMA that you need. So after looking at these two projections, it is evident that a lesion is located in the upper outer quadrant of the right breast. So it appears to have irregular margins and causing architectural distortion. High suspicious of a malignant lesion. It is also demonstrated in this projection that there is thickening of the nipple and there's a bit of skin retraction. So it's been noticed that this skin retraction occurs when the cancer spreads into the ducts and it pulls basically the glands inwards, causing that effect. Generally, when this occurs, the cancer is invasive and aggressive. So the magnification projection is important as it allows for improvement of the image's diagnostic quality. The benefits of magnification is increased signal-to-noise ratio and improved spatial resolution. Obviously, the size of the lesion is increased and can be characterised even further. However, because the breast is closer to the beam, the dose is increased. As demonstrated on this image, a focal compression shows an obvious mass to the right breast, as we discussed before in the upper outer quadrant of the right breast. So the patient did undergo hook-wire localisation. Ultrasound guidance confirmed the appearance of two lesions, the first being a 6mm hypoechoic satellite lesion, and the second measuring a 22 by 21 by 22 hypoechoic lesion, spiculated lesion. So after that hook-wire was confirmed, it was reported that removal of the lesion, and then the mastectomy was performed after that. Okay, so as we saw on that previous patient, the right breast demonstrated a suspicious satellite and spiculated lesion, highly suggestive of malignancy. However, for the purpose of this presentation, I would like to briefly make a point of common breast pathology. So there are two cancerous lesions which are most common. The first and most common is an invasive ductal carcinoma. So this means that the breast cancer, has spread from the milk ducts to the surrounding breast tissue structures. And the second most common cancerous lesion is an invasive lobular carcinoma. So this means the cancer has spread from the milk-producing lobules around to the surrounding breast tissue structures. And the most common benign lesion is called a ductal carcinoma in situ. So that also can be cancerous, but generally the abnormal cells are contained within the ducts, so it hasn't escaped to the rest of the surrounding breast tissue yet. In the case of a suspicious lesion being identified, it is likely to be biopsied under ultrasound guidance. If the patient's healthcare team makes the decision that the lesion needs to be removed, a hook wire will be inserted again under ultrasound guidance and localised in mammography prior to their surgery. So depending on the size and aggression of the singular or multiple lesions, a lumpectomy or mastectomy will be conducted. A lumpectomy only removes the lesion, where a mastectomy removes the entire breast and sometimes the lymph nodes as well. Generally, they will if the cancer is aggressive and invasive enough too. So in some cases, because of this, they may develop lymphedema. So this is where the patient's lymphatic system is unable to drain accurately, and this results in swelling. So unfortunately, they have to wear a compression sleeve as well. Okay, so unfortunately there is no cure, so they have to hold on to the pump. So an alternative to hook wire is iodine 125 radioactive seed localization, or 125 radioactive seed localization. This is the ROLLS trial and it's been introduced to a few hospitals internationally. A recent study from the American Journal of Surgery discusses this trial. The advantages are that the radioactive seed can be provided by NucMed and can be inserted 5 to 7 days prior to the surgery. This allows for a lot of scheduling flexibility and there's no risk of hook wire dislodgement or migration loss of localization. At this single institution, 3 surgeons treated 142 to 500 cases, and retrieval of the targeted